Hello, everybody. Welcome back. Just going to check that we've got all our participants joining. Give them a few more minutes before we introduce our guest speaker. I think we're good. What time is it now? So it's...
You're good to go in.
4 minutes past. Okay, so I am going to start with my first act as an official board member of Lupus Europe. I have the pleasure to welcome Dr. Arvind Kaul to talk to us about how key lupus drugs work and also how treatment adherence impacts disease activity and what we can do to make adherence simpler. Dr. Kaul is Head of Rheumatology and Lupus Patient Care at St George's Hospital in Tooting, London. He is also Chair of the Trustees at the Graham Hughes International Charity, which is dedicated to educating patients, doctors, and anyone else affected by antiphospholipid syndrome, a common comorbidity associated with lupus. He has a wide range of experience in general rheumatology, but has a special interest in connective tissue disorders, inflammatory arthritis, and lupus, having previously worked in the lupus unit at St Thomas's Hospital in London. Dr. Kaul is a supporter of our work at Lupus Europe and has given his time and energies to empower our patient advisory network. We are thrilled to have him back today as a speaker for this very important topic and at this year's annual convention. So I will stop sharing and let Dr. Kaul take it away.
Thank you very much, Amy, and it's nice to have such a wonderful turnout. And I'm sorry we weren't able to meet in person as we were a couple of years ago, but I'll now share my screen and let's hope you can all see that. So it's a fairly broad theme about how key lupus drugs work. What does taking my medication regularly mean? To cut a long story short, taking your medication regularly actually means your lupus will be better controlled and you will have better outcomes long term. That's the simple way of looking at taking medications regularly. But there are a lot of concerns, obviously, around taking medication itself. So I'm going to go through some of the key elements and the data which underpin why we use the medications that we do use. So let me just go to this slide. Now, you're probably going to look at this and think, oh my God, what the hell does this mean? Can't understand a word of this. This is a complicated slide, obviously, but I put it up really because condensing what causes lupus, what underpins disease activity in lupus is really quite difficult. This isn't a one-trick pony kind of condition where one thing alone will cause the disease. This is many contributors to the disease with good evidence that genetic factors which underpin the response of the immune system are variable in different people. So you have all sorts of contributors to the condition. On the left side of the screen, we have what is called the innate immune system, that bit of the immune system which is similar in everyone. Neutrophils, for example, these are the first line of defense for your immune system. And on the right side, we have what's called the adaptive immune system, that bit of the immune system which varies, which is more specific for different types of bug bacteria. And the way to look at lupus in many respects is really the immune system is trying to fight a bug which isn't there. There is no bug. And in many respects, the bug is actually your own body. And many elements of the immune system all contribute to lupus. And this has been one of the key problems with finding good therapies for lupus. So a complicated diagram deliberately shown to underpin why things might work and sometimes why they don't because of those complex interactions. So the sum total of all of those interactions is that lupus patients have a wide variety, not only of symptoms, what they feel, but also signs, what we can see as physicians. So Raynaud's phenomenon, where the hands go white, then sometimes red and blue, then internal organ damage, things like pericarditis or pleural effusions. These are areas around the heart and the lungs which allow fluid to waterlog those particular territories. Then kidney problems, which are particularly common and particularly serious in many lupus patients, occur in about 30% of patients. The bowel is affected in a large number of patients, both in terms of the medications we use, which can irritate the bowel, but also the lupus itself. Then we have blood complications and, of course, joint pains. We haven't even gone to the symptoms that patients feel particularly. So things like fatigue and tiredness, which are extraordinarily common and often the most debilitating feature of lupus. So complex nature of the condition and complex set of symptoms, which actually mean that general physicians, people who are not specialized in lupus, don't see lupus that often, can be often either fooled or into thinking this is something else, or may find it very difficult to diagnose lupus, meaning that the delay in diagnosis, which then contributes to the damage that the condition causes, can be quite long. So the sum total of the complexity together with the various problems that lupus can cause clinically mean there are inevitably drawbacks to long-term disease activity. And one of those, unfortunately, is mortality. And this study is nearly now 50 years old, so about 45 years old now. Murray Urowitz, who's still practicing in Canada, one of the very first people to look at lupus in a meaningful way with cohorts of patients, found that there was what's called a bimodal distribution of mortality with lupus. In other words, there was an early group of patients that had problems and may have died earlier, and that's the group of patients that often had very active lupus, which wasn't effectively treated. And then a second group of patients who tended to die rather later. And those are the groups of patients with lupus who didn't have particularly active disease, but this was kind of grumbling away disease that caused heart disease long term. And so this is rather better now than it was in 1976. It's a long time ago, but we still have a lot of work to do to try and reduce mortality in lupus. And that takes the correct strategies, the correct targets to be utilized to improve disease activity. As far as vascular outcomes, this is quite an important part of lupus. Any therapies that we use have to be able to overcome not only the clinical symptoms that patients feel, joint pains, fatigue, tiredness, skin rashes, etc., but longer term have to address the issue of the mortality associated with lupus. And quite often that mortality long term, as we've mentioned, is due to heart disease. And what you can see here on this table is you can see the observed number of events in lupus patients compared to the expected number of events that you'd see, and the ratio in the third column there. And what you can clearly see is the ratio is very high in stroke, overall coronary heart disease, and heart attacks, so myocardial infarction, which means heart attacks. So the observed to expected ratio of 10, 17, 7.5, and 7.9, whereas you'd expect it to be 1 if it was the same as the general population. It's much higher than the general population. So any drugs that we use have to be able to address a broad range of clinical symptoms, signs, as well as the long-term complications of lupus itself. So I'm going to illustrate what sort of strategies we use with a 31-year-old female journalist who has had 1 early miscarriage. This is a very generic, not a specific case, but it's a condensation of the sorts of cases that we see in our routine clinics. And this lady has had 1 early miscarriage. and is 34 weeks into her second pregnancy, and she's completely asymptomatic. She feels completely well. Clinical examination is normal. You might say, well, why am I seeing her? Well, she's been seen because she's had some blood tests, and one of the blood doctors that she had been referred to found that her white cell count was slightly low, and she had a positive ANA, positive Rho, LA, and double-stranded DNA. And these are all antibodies which can be associated with lupus, particularly double-stranded DNA. Now, the question is, does she have a diagnosis of any kind? She's got antibodies, and we were talking about polling questions earlier on. This might have been a good sort of instant poll. So this lady's got antibodies floating around, which are very specific for lupus. She's completely well. So does she have a diagnosis? The short answer to this is no, she doesn't. She doesn't have a diagnosis because the clinical symptoms need to be present for us to interpret the blood tests in context. Just having antibodies does not mean to say you have a disease. And a lot of general physicians will look at the antibodies and say this patient has lupus when she doesn't. She has no disease at all. So we'll come to the relevance of the antibodies in a second. What we see in this very good study is that looking at US Army veterans, as this study did, it's a very good way of looking at antibodies. And what this study found is that US veterans who, when they enlist into the Army, have to provide a blood test which is stored long-term for future reference. And this group went back to look at those stored samples in US Army veterans who were diagnosed with lupus to see, well, did they have these antibodies when they first joined up, before they were diagnosed? And lo and behold, a significant proportion of these patients, and you can see in that list there that 115 out of 130 lupus patients, one or more of the antibodies for lupus was present up to about 9 to 10 years pre-diagnosis. So looking at this lady that we've got as our case, she has no diagnosis, but is she at risk? And the short answer is yes, she is at risk. She's got multiple antibodies. And the graphical representation here on the right, the vertical line is when diagnosis happens. So the first manifestation of lupus is a vertical line. And looking at years before that, up to 5 years in this case, a significant proportion of patients have a variety of antibodies which are present well before diagnosis. So this lady may well be at risk of developing lupus in the future, even though she doesn't have it at the moment. And this is another way of really just addressing the data and visualizing it. And what you see here is the time before or after diagnosis on the horizontal line. So -6 years is where the study looks at, and the number of autoantibody types which rise gradually when diagnosis is made. And the clinical onset of disease, in other words, the first manifestation, usually things like joint pains, hair loss, for example, of lupus, to the diagnosis is quite short a time. And before that, patients have been asymptomatic for many years that have these antibodies floating around. The more antibodies you have, the more likely it is that you're going to develop lupus in the end. So this lady then delivers a healthy boy, and 6 weeks after delivery, however, she develops joint pains. She has the classical symptoms of lupus. So she has joint pains, hair fall, skin rash. Her urine is normal, and urine is one of the things that we test very regularly in our clinics because it's one of the key indicators of lupus kidney disease. Her blood tests show an ESR of 50 and a CRP of 5. These are inflammation markers, and inflammation tells us that there is some problem in the bloodstream. And this set of inflammation markers, with the ESR being high, the CRP being quite low, is quite characteristic of lupus. And in other conditions, ESR and CRP both go very high. For example, if you have an infection, ESR of 100, CRP of 300 wouldn't be unusual. And in many other conditions like rheumatoid arthritis, both ESR and CRP will rise. Not so in lupus. So it can be a very useful marker of lupus activity. So the diagnosis now is very different to when she was pregnant. The diagnosis now is that she definitely has lupus. She's got enough of the characteristic features. She's got all the antibodies that we need. She definitely has lupus. So for her management, the patient tried paracetamol. It wasn't particularly beneficial. She tried anti-inflammatories. They weren't particularly beneficial either. So we now have a decision to make about how we manage this lady. Do we give steroids? Do we give hydroxychloroquine? Do we do nothing? Well, we can't clearly do nothing. She has active lupus, and we know if we leave active lupus, that can cause damage in the internal organs like the kidneys, and patients feel unwell. Now, if we look at patients who have either lupus or a very early manifestation called an undifferentiated connective tissue disease, where they may have antibodies but don't have quite enough features to say they've got lupus. They might just have fatigue, for example. They might have some aches and pains, but they don't have all the characteristics of lupus. So in effect, a lupus light picture, if you like. What we see from the data is that these patients, if you leave them long enough, 4 or 5 years, they can progress into full-blown lupus. In other words, like the antibodies, the more you get, the more likely it is you'll get the lupus, very similar to symptoms. Once you start accruing symptoms, maybe 1 year having fatigue, the next year developing joint pains, the next year a little bit of hair loss, the more likely it is that you will accelerate off into lupus. 4 or 5 years after developing those kind of symptoms seems to be the at-risk period. And after that period, it seems to be less likely that you'll develop anything if nothing has progressed in that period. So you can get variations on a theme with lupus. And remember, we're talking about a spectrum with lupus and autoimmune conditions. Anything from the asymptomatic with full lupus blood tests to lupus to mild, moderate, and severe lupus, and anything in between. Unlike pregnancy, which is 0% or 100%, there's nothing in between. These autoimmune conditions can be undifferentiated, mild. You can have 1% of an autoimmune condition. You can have 100% of it, called lupus, and that can be mild, moderate, and severe. So think of these symptoms. Think of lupus really as a spectrum. It's not a homogeneous condition. So if we were to treat this lady, we would use steroids. And steroids have a long history. They were actually initially discovered by a rheumatologist who was awarded the Nobel Prize. That's probably the only rheumatologist that has been awarded a Nobel Prize some 70, 80 years ago now. And steroids have been used ever since as immune suppressing drugs with great success in many conditions. However, steroids have a checkered history, and lots of patients ask questions about, I don't really want to go on steroids, I'll put on weight, I'll have side effects. So let's go through some of the issues that patients might have with steroids. Now, before I show you this, I'm just going to go through the positives. Now, steroids have very good evidence in causing lupus to become or go into remission. They are very effective drugs. It is the reason we use steroids. They work quickly, they work very, very effectively, and they have a long history of usage. So we pretty much know what they will do and how effectively they will do it. Now, if we look at the flip side, well, why don't we use steroids all the time? Why don't we give patients steroids and nothing else? Because quite often, steroids are enough to control the condition by themselves, and they make patients feel better. So steroids really do have a profoundly positive effect on lupus disease activity. Now, if we look at why we don't give steroids forever, there are many studies, and in this studies, what you're seeing is on the vertical axis, the free of damage proportion of patients. And you can see, if you look at the key, patients who don't take any prednisolone are much more likely to be free of any damage with lupus and steroids compared to those who are on high dose steroids. And if you look at the dosing of the steroid, low dose, which was defined as below 7.5 milligrams, and no dose are very similar. So we try and aim for steroid dosing below 7.5 as soon as we can, compatible with the lupus disease activity. What are the effects of steroids if we can't reach that particular goal? Well, there are multiple side effects potentially, which include high blood pressure, include development of diabetes, often reversible when you stop the steroid, but skin thinning, easy bruising. We've got here osteonecrosis, which is something also called avascular necrosis, osteoporosis, which is one of the biggest concerns we have with steroids, but also ocular problems, eye problems, cataracts, diabetes I've mentioned. So what we try and do with steroids is, if we need to give high doses, we try and give them for the minimum time that patients need, and try and get them as quickly as we can down to below 7.5. And if you look at some of the data, some people are kind of almost stuck on 5 milligrams, sometimes 7.5 milligrams. Could we stop that if they've been on that dose long term with other medications? And the data really suggests that it's very difficult to stop steroids, because disease activity and relapses in patients who've been taking them long term and are stable tend to be more frequent. So steroids really are still, unfortunately or fortunately, very key to treatment of lupus and lupus activity. Now, this is one of the side effects that we see with steroid, and this is something called osteonecrosis or avascular necrosis. And the arrows there that you see are pointing to changes in the bone marrow in the knee joint on the left and the shoulder on the right, which really are where the blood supply to the bone has been cut off. And both lupus and steroids can cause osteonecrosis. And invariably, by and large, it involves replacement of the joint. So this is quite a big deal, quite apart from the pain that osteonecrosis causes. So we try and minimize the steroid, but we're in an imperfect world with lupus, a complicated condition. Steroids are a very good, effective drug, but they're a bit of a blunderbuss. And a blunderbuss really means they shoot in all directions, and they're not as targeted as we would like. But they are very effective and still very useful. So what about hydroxychloroquine? A lot of you who have lupus will be taking hydroxychloroquine, and it's one of the key drugs for Our Lady who's now developed aches, pains, skin rash, and hair loss after delivering her baby. Now, hydroxychloroquine is an anti-malarial drug, and it's been known about and used in lupus for over 120 years, and then much more recently was rediscovered when patients with malaria were treated for their inflammatory joint pains and found to have improved. Now, what this graph shows is that if you treat on the bottom graph with anti-inflammatories, what you see is that the number of antibodies actually doesn't differ from those who are taking NSAIDs or anti-inflammatories compared to controls. Now, if you look at the top graph, which is Plaquenil or hydroxychloroquine, the number of antibodies seems to be lower in those patients who take Plaquenil compared to those patients who don't. And Plaquenil or hydroxychloroquine seems to reduce the number of antibodies that people form. And that tells you this is an immunomodulatory drug. Very useful thought if you're treating patients, for example, who may have 1 or 2 symptoms, but not full-blown lupus, who you feel might be at risk of developing lupus. Should you put them on Plaquenil? The answer is yes, because not only may it help the symptoms, it might actually reduce the ability of the immune system to flare and cause full-blown lupus. So hydroxychloroquine is a very effective drug on several aspects of autoimmune conditions. Now, if you look at lupus kidney disease, one of the key types of lupus that we hope to avoid, what you see is if you look at patients who have biopsy-confirmed lupus kidney disease or lupus nephritis, hydroxychloroquine seems to reduce the incidence of end-stage kidney failure. Now, what that means is if you don't treat lupus kidney disease, the kidneys scar and they don't work. And that's a disaster because patients then need dialysis and then need transplantation, all of which affects the quality of their life and indeed affects their survival long term. So hydroxychloroquine, very early in the disease, not only may delay the production of antibodies, but it also seems to reduce patients going from kidney disease to end-stage kidney disease. And if you also look at other issues, for example, mortality, those who are treated with AM, antimalarials or hydroxychloroquine, do rather better than those who are not treated with antimalarials. They also have lower risk of blood pressure problems. So hydroxychloroquine is a really key drug. And there's more lines of evidence here that it has a protective effect in lupus. The graph on the left shows 151 lupus patients. And if you look at the probability of the patients having no damage, the probability is much higher in those patients who take hydroxychloroquine than those who do not. And if you look at the graph on the right, if you look at all causes of death in lupus, thrombosis, especially heart attacks, strokes, those patients who are taking hydroxychloroquine actually do far better than those patients who don't. Now, this is really important. Hydroxychloroquine is a freely available drug. It's cheap. And as you can see from the data, it's really effective. What's the problem? So the problem is it's a drug, it's a tablet. And frankly, if I had to wake up every morning to take a drug, I wouldn't like that either. And this is a problem because if you look at the studies, there's a very good French study which came out a few years ago. And what that showed was that although about 100% of patients who were given hydroxychloroquine said they took the drug, if you measure levels of hydroxychloroquine in their bloodstream, about 60% were not actually taking any of the hydroxychloroquine. And I guess it goes to a very important facet of the doctor-patient relationship that actually maybe doctors are perceived as people that you wouldn't really want to let down or tell them exactly what you're doing for fear of being judged. And my encouragement to you is please tell your doctor because we're here to try and help. And if there's a reason why patients are not taking medications, it's important we know that because of the benefits, for example, hydroxychloroquine brings around. So what about the eyes? So we can see that this was a study which has really changed the landscape for hydroxychloroquine. And what we see, so I'm just going to be mindful of time. What we see here is that this study showed for the first time a long-term study that eye problems are not as uncommon as we thought with hydroxychloroquine. And the graph shows that the lower the dose, the lower the risk. And a cutoff of 5 milligrams per kilogram of hydroxychloroquine is now what we tend to use and try not to go above to try and minimize eye risks with hydroxychloroquine. In our practice, although this study suggested a rate of 7.5% of patients with hydroxychloroquine develop eye problems, in our practice, it's more like 1% or so, but it's still 1%. And if you bear in mind, hydroxychloroquine can cause blindness, given it very high doses, and that's a historical problem that hydroxychloroquine has, then we need to be very, very cautious. But this is a rare phenomenon. It's not as common as as this study perhaps suggested in the UK. So this is the kind of scans that we do for hydroxychloroquine, what the eye doctors do. This is something called the OCT, and this has really changed the landscape for hydroxychloroquine retinopathy. It allows us a very detailed look into the eye, and this is why we think hydroxychloroquine-induced retinopathy or eye problems are probably more common than we thought originally. Very subtle changes can be seen on these very detailed scan, the optical coherence tomogram, it's called an OCT. And these are the kind of changes that the eye doctors will see, probably outside the remit of this talk. And important to bear in mind, the recommendations now are that 5 milligrams per kilogram should be the limit of hydroxychloroquine. Some people need more, some less. And there are some interactions, for example, with tamoxifen, which is used in breast cancer. Hydroxychloroquine is also used in patients who have Rho positivity, because there's a higher risk, perhaps 2%, of congenital heart block. And that means the scan on the left is an echocardiogram, and it basically just means the upper and lower chambers of the heart are not beating in synchrony. And that happens in the baby at around week 16 or afterwards, when the Rho antibody crosses the placenta. And there's some good evidence that hydroxychloroquine may reduce the risk of heart block in the baby. And the view on the right is the rash of neonatal lupus, completely innocuous. Don't worry about it. It will disappear in a few weeks, does not need any treatment, but that's one of the other consequences of Rho positive antibodies. Hydroxychloroquine seems to be effective in reducing the risk of the congenital heart block, and that's the take-home message. So let's just see if we can go further. Now, this lady has steroids, was given steroids, which helped, was worse off them. Hydroxychloroquine was partially helpful. Fatigue still prominent, and she still has active lupus. So we want to maximize her hydroxychloroquine, and for her joint pains, as she's not planning pregnancy, we added methotrexate. Now, these are the sort of immunosuppressants that we use in lupus currently. And there are 3 main ones: azathioprine, mycophenolate, and methotrexate. And all of these drugs are historically quite old. They're not that new. And they're all used in different circumstances. Methotrexate is used primarily for joint pains, but sometimes also for the skin. And the evidence here suggests that disease activity, so that the difference in the clinical trials here was a reduction of disease activity, as you can see on the first column there. And we use it quite often for the skin. It's quite an effective drug, but it's not safe in pregnancy. So we try and avoid it in patients who want to become pregnant. This lady, however, found it difficult to take methotrexate, and nausea is one of the main problems with methotrexate, and it stops people taking it. They often feel quite washed out. Increasing things like folic acid, which is one of the drugs that we give with methotrexate, is often one of the ways we circumvent that, but nausea is still quite common with methotrexate. So she admitted to not taking the drug for extended periods, and more worryingly, she's noticed leg swelling. And her urine now shows protein in it. And one of the measures that we use for kidney disease, the urine protein creatinine ratio, was very elevated. So normal would be kind of less than 10. She's got a urine protein creatinine ratio of 580, which is very elevated. She clearly has kidney problems with lupus now, and that's one of the worrying factors of activity. Methotrexate doesn't work for kidney disease, so we had to stop it, and she was not tolerant. But azathioprine, mycophenolate, and cyclophosphamide can be used for lupus kidney disease. And mycophenolate or cyclophosphamide have are the main indications for lupus kidney disease. This is what you see under the microscope. What you see, the arrows pointing to on the left, are what are called red cell casts. These are just red cells which have leaked through the kidney. And on the right, you'll see the staining pattern that histopathologists or pathologists will see under the microscope. The green is staining of antibodies in the kidney, and this shows active kidney disease. Now, our main treatments are cyclophosphamide or mycophenolate currently. Now, cyclophosphamide is a much older drug, and it basically cross-links DNA and inhibits the synthesis of proteins, particularly in rapidly dividing cells, such as immune cells. And one of the worries that cyclophosphamide induces in patients, and one of the key questions I get asked is, will it make me infertile? And infertility is a big deal because most of the patients that we see are quite young and female. So if you look at some of the data that we have, giving you one lot or one cycle of cyclophosphamide in this study and looking at a substance called anti-Müllerian hormone, which is a good indicator of fertility in a population setting, anti-Müllerian hormone levels do not seem to be any different if you're given one cycle of cyclophosphamide. The problem comes if you give much higher doses towards the right of this graph. If you just have one cycle, no real impact on fertility, but if you have several cycles, this may cause infertility, as we well know. So it's a reassurance, obviously, that cyclophosphamide, which is still an effective drug for kidney lupus, may not make you infertile and could be used quite safely, but several courses we try and avoid as a result. Now, if you look at mycophenolate, which is a tablet, and it doesn't cause infertility, but it is unsafe in pregnancy, what we see here is if you compare mycophenolate and cyclophosphamide, there's actually overall not much difference. And we therefore try and err towards mycophenolate whenever possible, with the knowledge that in the outcomes in clinical trials, it's equivalent to cyclophosphamide. And as cyclophosphamide can cause infertility, although given as several cycles, and mycophenolate doesn't do that, you would think that mycophenolate would be the preferred option. But lupus is complicated, and sometimes mycophenolate doesn't work, and we have to resort to cyclophosphamide. So it's not a simple kind of decision-making that we are faced with always. The side effects of mycophenolate compared to cyclophosphamide, well, they do vary slightly, a little bit more diarrhea with mycophenolate, and cyclophosphamide more vomiting and hair loss. So again, balancing up which the patient is more comfortable with and what the lupus is responding to is really quite important. So this lady had mycophenolate and then had this at the start of her therapy together with very high dose steroids, which we still use, and felt a lot better. She was reviewed 3 months later, and again now wished to have become pregnant in the future. That's clearly not an option now because lupus must be very well controlled for at least 6 months before pregnancy. And when you've got kidney disease, controlling kidney disease often takes 1 year to 18 months. So the other factors are mycophenolate and methotrexate are not safe in pregnancy, but azathioprine is. So should we then transfer in the second phase of therapy to azathioprine to allow this lady to become pregnant with those golden rules in mind? What we see with clinical studies is that mycophenolate seems to be superior to azathioprine. So if you were given the option and pregnancy was not an issue, and if this lady was 39, for example, it might be a more balanced decision because of pregnancy, you would say keep on the mycophenolate. You would say do not go on the azathioprine. The probability of having treatment failure, this graph on the left, is much more likely with azathioprine than it is with mycophenolate. And the probability of having a renal flare also is much lower with mycophenolate than it is with azathioprine on the graph on the right. So really, if you had the decision, you'd say stay on the mycophenolate, delay the pregnancy. Life is never so simple, and some patients, very, very keen on pregnancy. So you have to have a pragmatic view that maybe more steroids might be the way to try and plug this gap. Again, not ideal. So this lady found mycophenolate difficult to tolerate. Azathioprine unfortunately caused a rash, so that scuppered our plans to put her on medications which were safe in pregnancy. Joint pain still prominent, and whilst her kidneys had improved, they hadn't got to 100% better. She's still got active lupus. And so we explained to her the need to defer any pregnancy until the lupus is well controlled. And that emphasis has to be placed every appointment. So what about the new targeted drugs? What about rituximab? She's already on the oral contraceptive. And the other question is COVID vaccine. Should you give it or not? And the COVID vaccine will do that ahead of the other data is something that is quite important with rituximab. Rituximab is one of the few drugs that seems to actually increase the risk of COVID. And so we ensure all our patients are vaccinated before rituximab, if possible, at least 4 weeks before. And if they can't be, then within the first 4 to 8 weeks after rituximab. So COVID is a big deal with rituximab. Now, rituximab is one of the advanced therapies that we use. And again, complicated version of the causes of lupus. And this just summarizes the kind of clinical studies and the targeted therapies that we've used. And rituximab at the top of your graph then, next to the green antigen box, is something that targets B cells. And B cells seem to be quite key in lupus in maintaining the perpetuation of the immune response. It's an antibody, and it's given by intravenous infusion, given twice, 2 weeks apart, and it was first used in cancer therapy and lymphoma and gravitated to rheumatoid arthritis and subsequently to lupus. One of the issues with rituximab was that the large multi-center clinical trials, the Explorer and Luna studies, found that rituximab, disappointingly, was no more effective than placebo. Now, subsequently, we have been able to use rituximab in the public health systems, the NHS in the UK, simply because there was good background data from real-world clinical studies that it may be more effective than the clinical trials were telling us. And the BILAG-BR, or the British Isles Lupus Assessment Group Biologics Registry, have looked through several years' worth of data and found that actually rituximab can be effective. SLEDI2K is a marker of lupus activity on the left, as is BILAG. And what you can see here is the number of participants that improve is really quite large. Perhaps about 50% of patients improve with rituximab. And that's across a broad range of organ systems, which include not only joints, skin, fatigue, but also hematological components of disease, as well as heart, lungs, etc. So rituximab has a broad sweep and a good range of action. And I find it particularly useful in certain types of lupus, particularly those involving the joints. And as you can see, about 49 to 50% of patients do achieve a response in this real-world registry data, whereas the large multi-center clinical trials, which have more restricted entry into their clinical trial protocols, didn't show any benefit. Again, illustrating the complexity of lupus. Now, rituximab has been used even without steroids. I mentioned earlier on how steroids actually can have many side effects, even though they're very effective. This study carried out at Imperial College in London by Liz Lightstone and her group showed that if you don't use steroids at all and just give rituximab and give mycophenolate, you can get significant improvements in kidney disease with patients with active lupus kidney disease. And many patients achieved complete remission without any steroids whatsoever. And this really does involve a step change in our thinking, because steroids up till now and still comprise the best early treatment for lupus. We can look at now at some other therapies. If you look at this particular diagram, the box on the bottom left, many of the targeted therapies that we've used and are available or will become available really are in that bottom left box. Some, however, have not worked. And of the two that have, anifrolumab and belimumab are the two that seem to be most effective. Many of the others have been used in very small clinical trials where we haven't been able to interpret data, but may show some benefit perhaps in resistant cases in future. Now, belimumab is available in the public health systems throughout Europe now, and belimumab targets B cells, as does rituximab, but just in a different way. Belimumab targets the growth factor for B cells, so the chemical that allows B cells to grow and activate, whereas rituximab actually targets the cells themselves. So belimumab has a good benefit, a modest but good benefit. And if you look at the graph on the top, disease activity as measured by the Selena-SLEDAI score reduced more significantly in those patients who were given 2 different doses of belimumab compared to placebo. And if you look at the bottom graph, the probability of lupus flare, severe flare in this case, was more likely if patients were on placebo compared to belimumab. And belimumab is available now. It's funded by public health systems throughout Europe and can be a very useful addition to lupus armamentarium. It's intravenous and it's given once a month at 10 milligrams per kilogram. One of the elements of belimumab that seems to be present in colleagues that I've spoken to, although the data isn't fully formed, is that belimumab may be helpful, and one of the few drugs that seems to be helpful for lupus fatigue. Lupus fatigue is a complex set of symptoms which have multiple inputs. It's not just about disease activity. What you can see here is this group looked at the skin with belimumab and found disease activity before the drug was worse than the disease activity afterwards, but they also measured fatigue on the right 2 bars of the graph. Fatigue before and fatigue after. And you might think one bar is higher. Well, the higher is better. The way the score is measured is that this facet F score, the higher measure means less fatigue. So it's a little bit counterintuitive. But the fatigue after giving the drug was less than it was before. So belimumab may be a useful drug for many domains, and more recent evidence suggests it's very useful for kidney disease as well, and may be useful for many other factors, including joint pain and skin domains as well. Now, what about the future? Those drugs that I've gone through, if you look at hydroxychloroquine, steroids, if you look at rituximab, belimumab, as well as mycophenolate, azathioprine, and methotrexate are all available now. The future is still a little bit clouded, but there are some positives on the horizon. One of these is to use combinations of drugs. So can we beat lupus? That's in block capitals, simply because the study is called Beat Lupus. It's belimumab after rituximab in lupus. The theory is that because rituximab, very useful drug, suppresses disease activity, the problem is the growth factors for the cells that rituximab takes out seem to rise afterwards as the body senses there are not enough of those cells in the circulation. And then patients then get a flare-up of the disease. So using rituximab first, followed by belimumab, on this graph, seem to suggest that the double-stranded DNA levels are lower in those patients who were given belimumab after rituximab compared to placebo. And so this may be a useful exercise to do to combine belimumab and rituximab as a useful strategy. A newer drug called anifrolumab targets something called type 1 interferon, which may be one of the earliest chemicals which initiates lupus and some other conditions. And the evidence at the moment suggests that anifrolumab might be useful, and this on the top graph shows you the response called the Bickler response, which is just a BILAG, a composite lupus assessment tool. And the response is better with anifrolumab on the red line compared to placebo. And while statistical analysis wasn't done in this particular study, in the lower graph, the time to the first flare seems to be better, or patients who flared rather seem to be lower in those patients who are taking anifrolumab compared to those patients who are taking placebo. So this is a positive for the future. Anifrolumab may be one of those drugs that is added to our armamentarium. Now, there's another drug which again showed the disappointments that we have with lupus therapy, and that was ustekinumab, which is used in psoriatic arthritis and works very effectively in that condition. And it targets two chemicals called IL-12 and IL-23, which then have downstream effects on inflammation and organ damage. Now, ustekinumab was used, and initial studies suggested it was quite effective in lupus. However, Janssen, the company that makes the drug, eventually pulled the plug and decided actually it wasn't worthwhile continuing with the clinical studies because they didn't feel that they would be granted approval due to the lack of efficacy in lupus. And this was really disappointing. So we still have a long way to go in lupus. And perhaps one of the ways we should think about lupus is, are we treating it too late? Do we actually have an opportunity, if the public health funding systems allow us to do so, to treat lupus at diagnosis with those targeted drugs? And if you look at this study done by David Eisenberg's group at UCL in London, this showed that the red line, which are those patients taking rituximab, and the blue line, those patients who were not given rituximab at diagnosis. So normally would give steroids or methotrexate and mycophenolate or whatever at diagnosis. This was giving the targeted therapies, the advanced therapies, rituximab in this case, at diagnosis. Their steroid usage was far lower. The disease activity was better than those patients who were not given rituximab. So we probably are treating lupus too late and probably in too non-specific a way at this moment in time. So what do we hold for the future? So what we would like to do really is, of course, we want to treat lupus. Of course, we want to do the best that we can, but is it already too late if we're doing that? We're already catching patients who may have had the condition for 9-10 years, perhaps. We want to really ideally have biomarkers to intercept the condition and say, okay, we've got antibodies, 1 or 2 symptoms, let's give the right drug at this time. And in future, with genetic analysis very much on the horizon, could we actually identify those patients who will develop lupus and prevent those by giving the right medications, which could be as simple as hydroxychloroquine. So very many thanks for listening. I appreciate there's a lot of information there, and there's a lot on the chat, which I didn't really even go through, but I'm more than happy to answer any questions, and I'm very mindful of time.
I was going to say, thank you so much, Dr. Kaul. That was a brilliant presentation. And don't worry, I will catch up on the chat. Just before we go to the question and answer section, could we just run a poll for our members? Zoe's going to run it, just a few questions about adherence. Okay, so do you manage to take your medication regularly? Regularly take your medication? Never, almost never, sometimes, often, most of the time, almost always. I rarely miss a dose. I never miss a dose. Okay. So we should be getting those results in. Okay, do you manage to take your medication? So we've got, okay, so it's not, the majority is I rarely miss a dose and I never miss a dose, but there are a few that miss them always and sometimes. Thank you, that was very honest of everybody.
Just to say, we also have a few people from Facebook saying they take the medication almost always as well.
Oh, that's good to know. And they are anonymous, so you'd hope they'd be forthright. Okay, so we've got the next question. Do you tell your doctor the full truth about your adherence? We thought it might be interesting for you to see the answers to these, Dr. Kaul. A little insight.
And it's interesting also to comment on the differences. It'll be interesting to know what people feel, and it's not part of the poll, about the differences between what they tell their doctor and what they tell a lupus nurse, for example. I suspect the two will be different. It's
funny that it's that level of like, you don't want to let someone down, but you also need to be forthright.
Absolutely, correct, yeah. It is a difficult balance.
Yeah. So what results did we get there for those, Zoe? Okay, all right. So mostly yes, some yes, but might overstate it, and then a little bit of the latter. So mostly we're truthful with you. We promised, Dr. Kaul, truth.
That's nice to know.
Well, I guess it serves the patient and the doctor, but it's good that I guess that sort of hopefully means that people have good relationships with their doctors. Okay, we've got another question, Zoe. Okay, why would you miss a dose of your medication? And you can answer multiple choice for these. Forgot, negative side effects, not sure the medication is doing anything, reducing my chemical intake, I feel okay, so I need it less today, cost aspect, too expensive, or other reasons. I think that's very dependent on country too, because it depends on your healthcare system for the cost aspect. Okay, all right, majority forget. That's a resounding we forget. And I guess it's just, life gets in you. Some for negative side effects, that's 10%. And then other reasons, 10%, which would be interesting, but mostly not to do with chemical intake or not thinking the medication is doing anything. That's good to see. Okay, I think we've got another one, haven't we, Zoe? Okay, do you understand why you are taking your medications and what they do? One answer, please. Yes, for all of them. Yes, for most of them, but not all. Only for some. No, I would like to know. And no, I don't want to know. So if you can answer, that'd be great. Sort of assessing our flow of conversation and information, isn't it?
You should have had one with said, now I do.
Okay, so majority, 80% saying yes, they understand, and most of them. And that's good to know. There's some don't know what all the medications do, but nobody doesn't know what anything does. So that's good. So mostly we know. I wonder if that, it's interesting, isn't it? Is that a member reflection or is that a lupus community further afield reflection? But it's an interesting one. You got sort of half expert and, everyone's engaged, obviously, who's here. Did we have a fifth question or was it just four?
It was just 4 questions.
Awesome. Okay, so now I'm going to, just before the Q&A, Jeanette wants to quickly say something.
Yeah, just a few words. I'm sorry to interrupt. It's a very interesting presentation. Thank you so much, Dr. Kaul. Every time we listen to you, we learn something new. So thank you so much. I just want to say a quick congratulations on your birthday to Yvonne, our old Lupus Europe chair, who's with us today. So can we all please send positive vibes to Yvonne that you want to spend your birthday with us? It's really amazing. So happy birthday, Yvonne.
I shall do a rendition of the song for you later if you do request it.
Happy birthday.
Okay, so happy birthday, Yvonne, and now we'll move to the Q&A.
Yeah, thank you.
Yeah.
I haven't got the sound on, Peter, so it is computer. Yeah, I've had a big embarrassment this morning in church. I started the service by singing happy birthday.
Ah, that's lovely.
See, everyone loves you.
Had it been a little bit earlier, I would have had to go out and wash my hands, wouldn't I? Because we were singing happy birthday to wash your
disappear
hands.
at an opportune moment. I like that they surprised you. That's lovely.
Yeah. Thank you very much. That's lovely. Can I thank you, Arvind, for your talk. It was very good.
Thank you very much, Yvonne. It's good to see you.
Okay.
Happy
Lovely to
birthday.
have you, Yvonne. Thank you for joining on your birthday.
Yeah,
Bless you.
thanks very much. I love you all.
We love you
Thanks,
too.
Yvonne. Happy
Okay, so
birthday.
our first question is coming from Alan, is saying, one question on the antibodies abnormalities. You have shown the number of antibodies developing with people that do have a diagnosis of lupus, but do we have statistics showing how many people having the antibodies actually develop lupus or do not develop it, even in, say, 10 or 20 years later?
I'm not sure if that's the level of data that we have in any large studies, just as the ones I presented. The one I presented certainly suggested the majority of people will develop lupus, but the more antibodies, the better. Probably a good way of looking at it is, whilst we don't have much data on several antibodies, if you look at the anti-nuclear antibody, which is one of the key components of diagnostics, in lupus, often GPs will refer on the basis of a positive ANA, not because of a Rho or LA or anything like that. If you look at the data on a population basis, probably about 15%, in some studies, 20% of patients have an ANA which is positive. Now, the incidence of lupus is probably about 0.2%. So the vast majority of people who have an ANA positive will never develop lupus. And that's probably the most kind of robust way of looking at this, because as far as I'm aware, there isn't any data on who doesn't develop it. And in the veteran study that I mentioned, most people developed it, the majority developed lupus. But on a population basis, just looking at ANA alone, statistically, it's very unlikely if you have a positive ANA that you'll ever develop lupus.
Then it kind of leads on to Helen's asking, could the antibody levels become a diagnostic test? I mean, I guess the DSN, that it is part of the lupus test, isn't it?
It is. Double-stranded DNA is a very useful test. So what I would really emphasize is the test is only one, probably for me, a very small part of diagnostics and measuring disease activity. And by that I mean double-stranded DNA in many patients I have can be sky high and they're completely well, lupus well controlled. Double-stranded DNA in some other patients can be completely negative and they've got quite aggressive disease. So it isn't by any means a foolproof marker. There are patients, many patients who have double-stranded DNA. You may find probably in about 50% of those patients who have the antibody double-stranded DNA, that the level of the double-stranded DNA may reflect disease activity. But in many patients, it's not really that great a marker. And you have to look at not positive, negative, you have to look at the trend in those patients. And it can be useful, but remember, clinical parameters are probably the most useful marker. So if somebody's got a rising double-stranded DNA, for example, which is often a marker of kidney disease, for example, and their urine shows completely absent abnormalities of any kind, and they feel well, and that sometimes does happen, then I'm not worried. I wouldn't do anything preemptively. Just be cautious, of course, but no more than that. So the blood tests, useful. Clinical parameters, much more useful.
Sort of the whole picture, isn't it? Before you,
it is the whole picture. That's
like the lupus
correct.
is on a spectrum element that you mentioned.
Yes, indeed.
Okay, thank you. So our next question comes from Sabine, and it's saying, does osteonecrosis always lead to joint replacement? Can it be counteracted after discovery if the patient has to continue on steroids and is on blood thinners due to APIs?
That's a really good question. And osteonecrosis hasn't really been studied in large large studies in lupus specifically, but it depends how early it's found. And one of the key elements to this is identifying it early. Anybody that has resistant joint pains, for example, in one hip or one knee, for example, hip is often the commonest site, they should have an MRI scan, not an X-ray. An X-ray will not show it. Now, what if you find very early osteonecrosis? Could it be reversed? Short answer is yes. I've seen a couple of patients of mine who've had very aggressive treatment for their lupus. It's come under control, and the osteonecrosis seems to have slowly reversed. For more advanced osteonecrosis, and there are different levels, that's early osteonecrosis. More advanced osteonecrosis, generally hip replacement is what we would normally say is going to happen, but it doesn't need to happen all the time. In other words, it depends on the patient's symptoms. So if they've got quite advanced osteonecrosis, but they're managing well, there's no pain or anything like that, the patient doesn't need any hip replacement. The hip replacement comes when the patient feels too much pain or is restricted in what they can do because of the osteonecrosis. And pain is one of the key indications for joint replacement, and patients not being able to do or carry out their normal activities. Can we do anything about it? Minimize steroids, make sure the disease activity of the lupus, remember lupus is itself a risk factor for osteonecrosis, make sure the lupus is under good control. There is some evidence that clopidogrel, which is a blood thinner, may be effective, and we also use a drug called iloprost, which is a vasodilator drug, opens up blood vessels, and there's some evidence that iloprost may also be helpful in controlling osteonecrosis. These are very small numbers of patients, thankfully, that we see with osteonecrosis that need this. So long story short, does everybody need a hip replacement or a joint replacement? No, most people do not, but those minority of patients who have pain and restriction do need it.
Brilliant, thank you. Okay, so we've got a couple of hydroxychloroquine. So what about side effects? Can you be in the sun? And can it cause glaucoma? As somebody developed glaucoma and lost 30% of their sight. I'm not sure if that's in relation to hydroxychloroquine, or I think they're asking, is it? And effects of the sun.
So yeah, sunlight sensitivity and hydroxychloroquine are known about, and we do tell, it's a kind of a sun, sun concentrating agent, hydroxychloroquine. So it can cause an element of photosensitivity in patients who take the drug. I don't find that's particularly a big problem myself. Some people do find that they're more sun sensitive on hydroxychloroquine, and in any case, you know, with lupus, we tell patients to put very high factor sunblock, avoid the sun, wear a sun hat, wear sun-sensitive clothing, carry an umbrella around all the time. So most patients, I think, do that pretty well. There are invariably some patients where actually sunlight is not a problem for them and they don't flare and they've been out in the sun with no problems. But most patients, we would say, avoid it. So the incidence of sun sensitivity with hydroxychloroquine is quite low in my experience. It's not that high. And generally in Britain, where we live, where there's hardly any, it's not a huge problem.
Yeah,
so
struggle
I
with
don't
it
think
daily.
that's a big issue.
And I was like, no, sun's nice. Okay, and then in
was there
regard
another
to glaucoma, sorry.
Yeah, the glaucoma, sorry, yeah. So there's no evidence hydroxychloroquine causes glaucoma. It causes retinopathy, which is at the back of the eye. However, steroids are very common causes of glaucoma, of cataracts, which are problems really more at the front of the eye. Glaucoma is just raised pressure in the eye. And glaucoma can occur for many reasons, but steroids certainly can be one of the causes. Hydroxychloroquine isn't the cause of glaucoma specifically. And so if you've lost vision in an eye, how keen would I be to put you on hydroxychloroquine? Probably quite unkeen, because whilst the risk of any further problems with eyesight is low with hydroxychloroquine, there's always somebody who's outside that particular box. And we don't want to prescribe something that could even have a potential problem with the eyes if somebody's already partially blind or lost vision. So I tend to be very cautious with anything that can make vision worse, even though I'm very confident that hydroxychloroquine rarely does that. But rarely is not good enough for somebody who's losing their eyesight. Rarely is not good enough. It needs to be never.
Yeah.
And we can't say that with hydroxychloroquine at this moment in time. So pragmatic approach is avoid anything that makes eyesight worse. I'm comfortable normally with hydroxychloroquine, but if you've already got eyesight loss from glaucoma or any other cause, we don't want to even go there to think about making it any worse.
Thank you. Okay, so we've got, do the very high dose regimes of cyclophosphamide, often used in some EU countries, have an impact on fertility versus the lower dose cyclophosphamide regime developed in the UK? And that's from Zoe.
Yeah, again, a really good question. I haven't gone into details on cyclophosphamide, but in general, in the UK, we use what's called the Lupus regime. Now, what that means is we give a standard dose of 500 milligrams, and we give that intravenously 6 times every 2 weeks, so 3 months worth of cyclophosphamide. And using the data that we saw, which I presented, of anti-Müllerian hormone, which is this population-based marker of fertility, anti-Müllerian hormone levels do not really significantly fall with 1 6-shot cycle of Lupus cyclophosphamide. And so we're pretty comfortable giving cyclophosphamide if we have to for young women of childbearing age with that knowledge in hand. The problem lies with the higher doses. So in the States, for example, historically, cyclophosphamide was used at much higher doses and the infertility rate was much higher. And not only that, we mustn't forget cyclophosphamide at very high doses given over many different cycles also causes things like bladder cancer. So cyclophosphamide is one of these drugs that we want to really see if we can avoid, but we really can't. And one of my colleagues, Professor David Eisenberg at University College London, said one of his biggest regrets was writing a paper called Cyclophosphamide, Goodbye to All That, when rituximab came out. And the regret was, here we are in 2021, still using cyclophosphamide because of its benefit. So yes, one Lupus regime of cyclophosphamide seems to be pretty safe in not causing any problems with fertility. Higher dose regimes, however, will not be so safe. And so if anywhere in Europe or States or anywhere else, you're being given a very high level of cyclophosphamide, firstly, you don't need it necessarily because the Lupus cyclophosphamide may be just as effective. And secondly, your risk of infertility is going to be much higher with much higher doses of cyclophosphamide.
Thank you, Dr. Kaul. I am wanting to speak to you all day, but I think I'm being asked to limit it to a couple more questions. So I'll just say that Helen made a comment to say, not a question, but this long case study just shows that patients and doctors really do need to be a partnership, and we need to support patients to do this and inform doctors that it's necessary. So you going through that long,
up to that.
You know, it's great to see the progression of that patient. So I think for the last couple of questions, I'll see if Zoe's got anything on Facebook Live to ask.
Yes, thank you, Amy. We do have a number of questions from Facebook Live. It's just a few, perhaps, if we've got enough time. Emma says, hi there. Thank you for this interesting and informative talk. I was wondering whether medications for SLE, particularly anti-disease modifying drugs, can impact blood results. My ANA has always been positive, with high positive anti-DS DNA. However, has turned negative since starting azathioprine. How would this be interpreted? Thank you.
Okay, so interpretation of blood results sometimes is quite difficult, and you know, we've had patients who've had negative ANA but whose lupus has flared. So it's not a good way of judging the activity of the lupus. Antibody levels go up and down all the time, and if you measure even on consecutive days, you'll find different levels. So my emphasis would be on not looking at the antibody levels per se, particularly ANA. It doesn't really help. And again, this thinking that you've got to put the antibodies into context is much more important. So don't even try and interpret the antibody. Really, the question I would say is, has the azathioprine helped you? Has it done anything useful more than has it made the ANA negative? Because if you feel well and the azathioprine has symptomatically helped you, then whether the ANA is positive or negative is irrelevant.
Okay, thank you very much for that. We have Another question from Facebook. My doctor says that in Belgium there aren't many lupus patients with anti-DS DNA. Could this be because our labs can't track it?
Yeah, lab tests for double-stranded DNA vary, and the parameters by which labs set their levels of cutoff, if you like, for what is negative and what's positive can vary. Double-stranded DNA generally occurs in about 50% of lupus patients, but it will vary, and the test may determine positive and negative. Yes, that's certainly true, but I don't think it's just the lab, and I don't know that level of data actually in Belgium. I wasn't aware of that. I'd be surprised if it's very much different to the rest of Europe, unless there's something in the water in Belgium that we're not being told about. But in general, labs do vary in their consistency, and that's because different kits are made by different manufacturers or have different cutoff points for what is positive and negative. That could be one of the answers. But it'll be interesting to see what level of data there is in Belgium compared to the rest of Europe. I don't know if there is any such data, but I don't think it's likely to be a generic issue that the population in Belgium is different to the population in the rest of Europe. I think it's probably, the level of data that we need to establish that probably isn't there. So this may be what's called anecdotal data. It may have been something that you think, well, is there less? And when actually, if you look at all the data, which we don't really have in that respect, you might find that's not the case. So I'd be surprised if it's very much different, but labs do vary in the cutoff of double-stranded DNA for sure. And we have that even in the UK, in our own labs, where different hospitals use different kits. Some have positive double-stranded DNA, some negative. And that's why it's so important to focus on the clinical symptoms. People worry too much about the blood tests. If you've got the right clinical symptoms, and sure, you might have a positive ANA, or it may be weakly positive even. If you've got the right clinical symptoms, then you've got the condition. That's the important thing, really, much more than the blood tests.
So, Dr. Kaul, these are amazing, and we're getting the questions are flooding in for you. And I want to kind of put you on the spot that we basically don't have the time now, but would love to have you back for possibly a webinar in the future or to answer these questions, because we've got lots on Facebook and lots more on Zoom, but we need to move to our breakout room to answer some questions. So I think it'll be to be continued, if that's okay.
Yeah, of course it is. Delighted to do that.
I really appreciate all the insight you have, and it's a vast subject and a vast amount of information we want to learn from you. So thank